Good morning and welcome back to this series of conversations on matters relating to healthcare research. We looked at observations in the last talk, the one that we aired last Sunday. In this particular talk, I would like to carry forward that conversation with a particular focus on the poverty of data or data poverty relating to healthcare research in India or coming from healthcare research. Now, it comes from one particular area of concern that despite having among the most populous nations in the world, a large number of people, despite being a population with a large burden of illness, we don't seem to have too many clinical guidelines that are derived based on data from our population. Most of the guidelines of clinical care, the clinical care guidelines, most of the public health guidelines come from populations outside our country. To be more precise, they are usually an American or a European guideline that's being followed here. Now, is that appropriate enough? There are several problems with that, as well as several good things with that. One, let's look at the good things first. Among the good things that are there is the scientific rigor, possibly, that has gone into the development of these guidelines and that they have been tested and validated using scientific processes and then applied. The limitation is that these guidelines are derived from populations in developed countries that have different resources, that have got a different genetic makeup, a different environmental makeup. And hence, does the application of these guidelines as it is to our population actually account for possible genetic and environmental differences? And do they then hold good to apply in our population? Now, the key point to remember here is that they might hold good. They might be good to apply directly onto our population, but that we need to evaluate it. And we need to see whether we need to adapt those guidelines based on our own genetic and environmental makeup, the concerns that we have. Now, as we are looking at that whole process, it's a bit surprising that despite seeing so many people with illness, with ill health, with various diverse diseases and conditions, despite having a large population based to, let's say, a large sample size to base your statistics upon, to base your inferences upon, to test your inferences, we don't seem to have guidelines, clinical guidelines, many clinical guidelines that are derived from our own population. And when they're derived, they are more often than not consensus guidelines based on Delphi guidelines, based on consensus or a group of experts that are drawing from their own experience and they're sitting together and then looking at what is ideal and putting that out as consensus guidelines. The question is, are these consensus guidelines further validated for use in our population? Are they refined? The whole process of guidelines development is interesting because the environmental interactions with the person changes. There's a change in the external environment. There's a possible change in the internal environment as nutrition and other factors improve. And hence the guidelines may also have to be dynamically evaluated and adapted and changed as necessary. So there's a whole process of, if we can call it research, evaluation that's possible through this development of a guideline. Equally important, the development of guidelines based on local population context and local population needs actually help to optimize clinical care and provide better outcomes for the local population. A case in example, since we have over 3 crore births and we keep adding to our population quite a bit, Let's look at childbirth as an example, and let's look at severe maternal morbidity or severe maternal illness, near miss, as an example. And we see that we have a high maternal mortality ratio that is declining. We have severe morbidity in good numbers. I shouldn't say good numbers, but in large numbers. And we have a population that needs care. And yet our guidelines for the management of acute critical care in pregnancy, the management of near miss in pregnancy. Near miss is a condition that's very severe maternal morbidity where the patient almost died from that condition, but survived. And so that's near miss, a near miss from death. So we have a large number of near miss. We have acute critical care illnesses in pregnancy. We have severe preeclampsia, we have eclampsia, we have the HELP syndrome, we have amniotic fluid embolism. We have a whole set of acute critical care conditions in pregnancy. Yet our management guidelines invariably are derived from guidelines that have been developed in the more developed countries. The reason why that's so is because the guidelines are coming from there. They worked on it, they have developed it, and we have sort of used those guidelines. Let's look at it from a different aspect, from the fetal aspect. And so we have fetal ultrasound parameter assessments that are done during pregnancy. We look at fetal growth. We look at how the structures are, how the fetal structures are. We look for any abnormalities. We look for Doppler parameters, functional parameters of the fetus, the baby growing inside the uterus. And yet all the parameters of normality, or what is normal, are invariably derived from the more developed populations. And we know for a fact that our growth, our body structure is different from those populations. Yet we find that there is not a local population nomogram that's being developed to look at our population parameters and the application and to determine what is normal and what is abnormal. And that's there even within the machine, within the ultrasound machine. We don't see a parameter or a set of parameters that say that these are the normal standards for the Indian population. So when we say that the fetus is not growing properly, when we say that the fetus is growing properly, we have to keep in mind that we are basing it on a standard that's derived from a population that may not be similar to our population. And so is this assessment true? Is that why we underestimate or overestimate fetal growth restriction? And it has consequences. So what I am trying to lead you to is to start thinking over. Why do we not have local population parameters for our country? We cannot blame it on the absence of people. We have a large population. We cannot blame it on the absence of illness or ill health. We have a large burden, a huge burden of illness and ill health. It's also related to the large population size that we have. But in absolute numbers, we have a large population available. So we can't say that we don't have the diseases to look at. We can't say that we don't have the normal population to look at. We can't say that we don't have numbers of people to look at. Do we have the resources? Well, we have definitely we have the basic technological instrumentation that is necessary to derive local population nomograms. Whether it's a mean arterial pressure, whether it's a blood pressure, whether it's the body mass index, the waist-hip ratio, whether it is the blood sugar levels. We can do all of that, but we don't have clinically validated nomograms for many of these parameters. And that's an area that we need to look at. So then why do we not have it? Is it because, what's the reason for it? When you have the population, you have the illness, when you have the instrumentation possible for it, why do we not have these normal parameters or the nomograms, as we call it, that help us discriminate between what is normal and what is abnormal? Why do we rely on population parameters that are coming from the more developed nations that have a different population makeup, demographic makeup, as well as a phenotypic and genotypic makeup, and a different environmental interaction that can change the whole? This is an area that we need to really look at because it impacts and influences on the clinical management algorithms that we use. And therefore, it can impact and influence on the outcomes that we see in our population. So why is there a poverty of data on the normal population parameters that we have? And as we look at that, I would like you to also think over whether our training is equipping us to really look at the norms and to understand the norms, or is our training focused almost entirely on our determination of what is abnormal without really understanding what is normal? So when we see a particular sign, when we see a particular condition, and when we call it as abnormal, do we really have the understanding of when that particular sign transcends from normality to abnormality? It's along a spectrum. And when it's severe, moderately severe, we know that there's a clear discrimination. When it's at the milder levels, when it's at the bridge between normality and abnormality, do we really train ourselves to look at those bridges, those areas where it transcends, and to make out the differences as they appear? Is that important? Well, to rephrase it in a different way, it does make sense if we look at it in the management, from a clinical management perspective or a public health manager perspective, where we now take a step back and say, when I see this abnormality, do I really have to treat it? Is it necessary for me to intervene at this stage? What happens? Or what's the natural course, or what's the natural progression of that abnormality? Does it really progress to something that is very severe, that needs an intervention, where an early intervention can help? Or does it progress so slowly, or even not at all? So it can be something that is different from normal, but it may not progress, or it may progress so slowly that I can as well as let it be without an active intervention. So when we observe, we need to also be looking at carefully at the intersection between normal and abnormal. We need to be looking carefully at the definitions, at the definition intersections of normal and abnormal. When does it transcend from normal to abnormal? And how we define abnormal. Is it based on a functional loss? Is it based on an anatomical change? Is it based on that 95% of the population have this particular format, pattern, and so that is normal, and the remaining 5% are abnormal, 2.5% on that side and 2.5% on the lower side are abnormal? Does the intersection of normal and abnormal change as the environmental conditions change? And are the consequences of abnormality to an extent that an intervention is necessary to stop further deterioration or to take care of any other complication that may arise? So when do we intervene? Now, these are clinical decisions that we take on a routine basis. Now, I brought in the issue of the poverty of data on normality, on normograms, at the beginning to illustrate this particular point, that if we really don't know the population parameters of normality within our population, if we really don't know that, and if we don't keep evaluating that at regular intervals to make sure that they are not changing, or that if they have changed, that we are refining, if that evaluation is not happening, then the possibility that we might be treating a number of people who are normal and who may not need treatment comes up. As does the possibility that we might be missing a certain proportion of people who are abnormal and who might need treatment. Now, usually this intersection is between the normal and the very mild, and so that intersection may not possibly create too much of a trouble. A blood sugar of 126 and a blood sugar of 130 may not possibly create too much of trouble. But it does give us a pointer to look at how we define normal and abnormal, because much of clinical practice today is oriented towards the management of the abnormal. And when it's oriented towards the management of the abnormal, we have to make sure that we understand what abnormal is. If the management, clinical or public health management, is oriented towards the preservation of normal, which also happens, preservation of wellness, preservation of normal, even then the understanding of what is normal and why do we call that as normal becomes important. So I think we should step back, take a step back and look at how do we determine what's normal? How do we determine what's abnormal? Whether it's a clinical sign, whether it's a symptom, whether it's a laboratory sample result, whether it's an imaging result, a CT or an MRI report or an ultrasound report, whether it's a population parameter. What are the bridges? Where is the bridge? Where's the intersection between normal and abnormal? And where is the intersection between we need to treat this definitely, and we need not treat this even without treatment. This will resolve, or its natural progression is such that it will not lead to further severity. It either resolves, it stays as it is, with minimal or no discomfort, or it might progress. So we need to understand that part also. So just some thoughts for you to think over as we are looking at data, as we are looking at the lack of data, as we are looking at the numbers of ill health that we have from our country. We are looking at the large population that we have, as we are looking at the low doctor to patient or suboptimal doctor to patient ratio that we have in this country. And we look at the poor healthcare infrastructure and resources and the utilization of those resources. I think we also need to step back and start looking at the entire spectrum that underpins the care that we are providing, and to check whether we are optimally, or we are able to optimally manage these conditions, and whether our curriculum, our medical or healthcare curriculum, is oriented towards training or providing the skills for the learners to start making these distinctions. So think over this, have fun, and we'll meet again next Sunday. Thank you so much.